Hello, my name is Christina Pierre. I'm a clinical chemist at Penn Medicine Lancaster General Hospital, the Section Director of Clinical Chemistry and a Technical Supervisor of Coagulation. I'd like to start by thanking Dr. Yip and the Lab Roots team for inviting me to present at the Clinical Diagnostics and Research 2022 webinar. Today, I will be discussing the use of race and ethnicity in medicine, and we'll discuss a laboratory medicine case example that demonstrates the nuances associated with using race as a biological classifier. To get some housekeeping out of the way, I have nothing to disclose. Our learning objectives for today are to describe the context of race, ethnicity, and genetics, discuss the limitations associated with using race-based classifications to describe biological differences, and critically assess the utility of race and ethnicity in science and medicine. Increasingly, the use of race as a biologic classifier in medicine is being examined. Some argue that race is a proxy for population genetics and is therefore clinically useful. Others argue that race is a social construct and that using race as a biologic classifier can lead to systematic differences in care, which can exacerbate or perpetuate racial and ethnic healthcare disparities. To guide our discussion today, I would like to start by defining the concepts of race, ethnicity, and genetic ancestry. Race refers to physical differences, for example, skin color, hair, texture, facial features, that groups and cultures consider socially significant. Examples of races are African American or Black, Asian, Aboriginal. Ethnicity refers to shared cultural characteristics such as language, ancestry, practices, and beliefs. In the context of North America, an example of ethnicity would be Latino. Now, when we talk about the definition of ancestry, this is very much dependent on the context in which the word is used. It can either refer to individual family trees, an individual's genome, or genetic similarities within a population. When we talk about ancestry in the context of precision medicine, we talk about genetic ancestry. That is, genetically inferred ancestry that is measured by inherited genetic variation and correlates with an individual's genealogic ancestry. Genetic ancestry varies across geography and changes slowly over generations and with admixture. Importantly, genetic ancestry can be measured using reference panels of DNA polymorphisms to infer an individual's continental or subcontinental genetic origins. So how are the concepts of race, ethnicity, and genetic ancestry related? In a study that was conducted using genetic ancestry data from 23andMe customers, the authors examined the probability of self-reporting as African American as a function of the proportion of genetic African ancestry in a cohort of self-reported white and Black customers. Generally, self-reported ancestry positively correlates with genetic ancestry. However, hopefully you can appreciate that there are individuals in the gray zone of this graph who have significant contributions of African ancestry, but do not self-report as having African ancestry, perhaps because they are unaware. To further demonstrate the relationship between self-reported identity and genetic ancestry, the authors created ternary plots demonstrating African, European, and Native American genetic ancestry in groups of self-reported African Americans, Latinos, and European Americans. Each point within the ternary plots represents a self-reported individual and is positioned within the triangle reflecting the amount of ancestry estimated from each population. Again, in this figure, historic admixture that occurred during colonization, chattel slavery, and multiple waves of immigration from different continents to the Americas has resulted in mixed genetic ancestry, particularly in African and Latino Americans. So to emphasize, while genetic ancestry is a measurable biological parameter, race is a product of historical, social, and political processes, and therefore it captures the disproportionate impact of social determinants of health such as healthcare, access and quality, and economic stability on minority populations. Generally, persons of lower socioeconomic status experience more negative social determinants of health, and racial and ethnic minorities are overrepresented in low socioeconomic status groups in the United States. Additionally, race captures systematic differences in care, that is, the impact of systemic racism on racial and ethnic minorities. We can use kidney disease to demonstrate the intersection of low socioeconomic status and race on healthcare outcomes. This figure is from the United States Renal Data System 2022 annual report and shows the distribution of social deprivation index score in older adults with chronic kidney disease by race and ethnicity in a Medicare-Medicaid dual-eligible population. The Social Deprivation Index, or SDI, is a composite measure incorporating 7 demographic characteristics of neighborhoods collected in the American Community Survey. These demographics are as follows: percentage of population living in poverty, percentage with less than 12 years of education, percentage of single-parent households, percentage living in rented housing units, percentage living in overcrowded housing units, percentage of households without a car, and percentage of adults under 65 years of age who are non-employed. A high SDI represents more deprivation, and a low SDI corresponds to low deprivation. The percentage in the highest SDI category was more than 2.5 times as high among Black beneficiaries at 57%, and more than 3 times as high among Hispanic beneficiaries at 64.6%. as among white beneficiaries at 20.6%. Only 12% of Hispanic and 16.4% of Black beneficiaries lived in neighborhoods in the lowest range of SDI scores, that is, lived with the least deprivation. If we look at the rate of living donor kidney transplant in dialysis patients by race, ethnicity, and social deprivation index, we can see that within all racial and ethnic groups, patients living in neighborhoods with high SDI scores, that is, more deprivation, had much lower rates of receipt of a living donor kidney transplant. However, large disparities by race and ethnicity persisted within and across strata of neighborhood SDI, demonstrating systematic differences in health outside of socioeconomic impacts or social determinants of health. For example, Black patients living in neighborhoods in the lowest SDI category, that is the least deprivation, had lower rates of receipt of a living donor kidney transplant than white patients living in neighborhoods with the highest SDI scores. Further, as the demographic characteristics of the United States population changes, self-reported race may become even more nuanced. In this figure from the 2020 census comparing the percentage change in race groups between 2010 and 2020, we can see that the proportion of each racial group reporting that they are mixed race has increased significantly between 2010 and 2020. In spite of our knowledge as scientists and clinicians that race is an imperfect surrogate for genetic ancestry, a systematic review of the use of African ancestry in genetic studies that was published in 2021 showed that 58.7% of studies used self-reported race as a genetic category in examining genotypes associated with clinical symptoms, disorders, and diseases. So to summarize this portion of the talk, self-identified race and ethnicity capture the impact of systemic racism and sociocultural influences on an individual's health status, while ancestry captures biological attributes, including genetics, which can also influence an individual's health status. Now let's examine the potential negative effects of using race as a biological classifier using a hemoglobinopathy case study. Hemoglobinopathies refer to disorders in globin polypeptide biosynthesis, structure, and function. They can be structural due to substitution, deletion, or addition of one or more amino acids in the globin chain. They can also be quantitative, as in thalassemias, in which case it impacts the amount of globin produced, or hemoglobinopathies can be caused by a combination of 1 and 2, that is, structural and quantitative changes. It's important to note that hemoglobinopathies may be asymptomatic disorders, as in hereditary persistence of fetal hemoglobin. Sickle cell disease refers to a group of autosomal codominant hemoglobinopathies in which there are 2 mutant beta globin alleles with at least 1 HBS allele, such as HBSS, HBSC, or HBS beta thalassemia. These mutations favor polymerization of the hemoglobin molecule, causing red blood cells to assume a sickle shape. Now, sickle cell disease is most prevalent among people of African and South Asian ancestry, and it is hypothesized this is because these individuals with sickle cell trait, that is, 1 copy of the sickle allele, have a selective advantage with respect to malaria. Clinical manifestations of sickle cell disease include cardiothoracic defects, such as acute chest syndrome, nervous system defects, including acute ischemic stroke, reticuloendothelial system defects, including anemia and hemolysis, musculoskeletal defects, including vascular necrosis and leg ulceration, urogenital system disorders, such as renal failure, and gastrointestinal system defects, such as gallstones. Now, I want you to consider your own clinical practice if you are responsible for signing out hemoglobinopathy cases. Does a patient's race, name, or country of origin influence your diagnoses in these cases? Let's look at the case of a 12-year-old white female with a complex history of sickle cell trait. Her history was significant for splenectomy, frequent pain crises, infections, and acute chest syndrome. She presented to the emergency department with complaints of severe back and leg pain and was administered morphine and discharged upon improvement. Within 24 hours, she returned to the emergency department with labored breathing and tightness and pain in her chest. She was tachypneic with sinus rhythm tachycardia. A chest X-ray revealed infiltrates in her lower pulmonary lobes, and she was diagnosed with acute chest syndrome. She was administered morphine, fluids, ceftriaxone, ondansetron, and oxygen. During her ED course, she acutely decompensated with increased oxygen requirement, became febrile, and experienced intensifying pain. Her CBC results revealed leukocytosis, normocytic normochromic anemia, anisocytosis, and an increased reticulocyte count. Sickle cells and multiple other cellular abnormalities were observed on her peripheral blood smear. Hemoglobin analysis that was performed by high-performance liquid chromatography showed patterning consistent with sickle cell trait, as had been seen in her previous evaluations, with 54.3% hemoglobin A and 38% hemoglobin S. These results were confirmed using several other protein-based electrophoresis methods. Acid and alkaline electrophoresis, as well as isoelectric focusing, yielded results consistent with the HPLC analysis. Now, one significant limitation of protein-based separation methods for hemoglobin analysis is that electrophoretically silent hemoglobin variants that co-migrate with wild-type hemoglobins can go undetected. Protein-based separation techniques rely on amino acid substitutions that produce changes in polarity and overall molecular net charge. In the case of electrophoretically silent hemoglobin variants that result from amino acid substitutions, there is no alteration in the polarity or net charge of the molecule. Multiple hemoglobin variants show sickle cell patterning on protein-based separation techniques, including hemoglobin S Providence, hemoglobin S Arlington Park, hemoglobin S Antilles, and hemoglobin S Quebec Quarry. Hemoglobin Quebec Quarry is a benign beta-globin chain variant. When present in combination with hemoglobin S, hemoglobin Quebec Quarry promotes polymerization and red cell sickling due to increased donor-acceptor interaction at the site of substitution. Patients with hemoglobin S Quebec-Cori genotype experience severe acute chest syndrome and vaso-occlusive pain crises that are responsive to hydroxyurea. Now, given the discordance between this patient's clinical presentation and her hemoglobin analysis results, a sample was sent for sequencing of the hemoglobin alpha and beta globin loci. This analysis confirmed the presence of hemoglobin S and also found that the patient had a hemoglobin Quebec-Cori allele. These results were further confirmed by high-resolution accurate mass spectrometry. Notably, the College of American Pathologists stipulates that samples positive for hemoglobin S by any method must be confirmed by a second method. However, genetic sequencing and mass spectrometry are not routinely ordered as first or second line testing for hemoglobin analysis. Now, unfortunately, despite multiple hospital visits with a clinical presentation that was largely inconsistent with sickle cell trait and more consistent with sickle cell disease as evidenced by history, an electrophoretically silent hemoglobin was not suspected until this visit. It's possible that the patient's race, a white child, may have delayed appropriate treatment in this patient. While it is true that sickle cell disease is most prevalent in African Americans, cystic fibrosis is most prevalent in white Americans, and Tay-Sachs disease is most prevalent in Ashkenazi Jews, we must remember that these racial and ethnic categories are imperfect surrogates for population genetics. In 2020, a study looked at the efficacy and equity with which ethnicity-based carrier screening captures recessive disease risk in a cohort of 93,419 individuals undergoing a 96-gene expanded carrier screen. At the time of publication, carrier screening guidelines recommended testing for a limited set of conditions based on a patient's self-reported ancestry or self-reported ethnicity, rather. The study partitioned participants into self-reported ethnicity plus SRE. That is, the ethnicity that was selected on the requisition form, on the patient's requisition form, and negative SRE. That is, an ethnicity that was not selected by the patient. The authors then further subdivided these groups based on the corresponding genetic ancestry, resulting in high, medium, and low ancestry subgroups. 7,100 or 7.6% of patients in the entire cohort self-reported as African or African American, while 2,800 or 3% of the 7,100 other patients had medium African genetic ancestry and did not self-report as being African or African American. The latter group, that is, participants that did not self-report as African or African American, but had a medium contribution of African genetic ancestry, would not have been screened under ethnicity-specific guidelines. Yet, this group had a 3.6-fold higher risk of being a carrier of a hemoglobin beta chain-related hemoglobinopathy, and a 3-fold higher risk for being a carrier of alpha thalassemia relative to self-reported individuals or individuals that rather did not self-report. Among all patients with medium African genetic ancestry, only 16% self-reported as African or African American. The others tended to self-report as Hispanic, 47%, or mixed or other Caucasian, 25%, meaning that self-reported ethnicity-based guidelines would not have captured their elevated risk of being carriers of hemoglobinopathies. The insufficiency of self-reported ethnicity as a means to identify elevated carrier risk for particular conditions was true for other ancestries as well. For example, Ashkenazi Jewish participants. Based on this premise, in 2021, the American College of Medical Genetics and Genomics recommended that carrier screening paradigms should be ethnic and population neutral. To put it simply, it is impossible for race as we recognize it clinically to provide perfect sensitivity and specificity for the presence of a DNA sequence variant. I will close with this question. Does race have a place in medicine? We know that self-reported race or assigned race, ethnicity, and ancestry correlates with genetic ancestry, but that this correlation is imperfect as demonstrated in our case study and in the carrier screening study. We also know that using surrogates such as race, ethnicity, and skin color can result in missed diagnoses and improper estimation of risk factors. The increasing admixture of the US population further complicates the use of race and ethnicity as proxies for population genetics. We also know that social determinants of health drive disparities in disease burdens among people of different races and ethnicities, and hence race and ethnicity must be considered in this context as we strive for more equitable clinical care. Thank you so much for your attention today. Please do not hesitate to reach out to me via email with any questions that you may have.